Hi there. My name is Dr. Bogdan Milojkovic. I'm Medical Director for Nova Biomedical, and I'll try to use next 20-25 minutes to briefly tell you the story about magnesium and actually why do we measure magnesium, especially why it's important and what are the differences in between information that we get from measuring ionized magnesium versus total magnesium. As with any story, first it's important to answer the question why. So why do we actually measure magnesium? If you look in publications, you just try to search PubMed for magnesium and put something like forgotten electrolyte, and you look for past, 50 years, you can find articles showing up every couple of years with a similar title: magnesium, forgotten electrolyte, forgotten cation, neglected cation, and so on and on. It goes back here on the slide in 1979, but actually I found some articles in the 60s and 50s. And the recent one I found, which is not here on slide, just I think a couple of weeks ago, with a very similar title, scientific medical community is still talking about magnesium continuously, like forgotten electrolyte, and it's been like 50 years like that. So here on this slide, we have summarized roles of magnesium in maintaining human health and some of the effects hypomagnesemia can have on a human body. So basically, magnesium is essential for good health, as it is the second most abundant intracellular cation, being cofactor for over 300 enzymes in the body. And it's involved in lots of fundamental functions in human body, starting from sodium, potassium, and calcium ATPase pumps in the membrane, regulation of other cations in human body, regulation of vascular smooth muscle tones, skeletal and cardiac contractility, neurotransmission, oxidative phosphorylation, introduction of energy, free radicals metabolism, inflammation, platelet coagulation, atherogenesis, blood pressure regulation, regulation of glycemia and insulin levels. And if you just look at the list here, you can more or less say that any and a lot of processes in human body will one way or another have magnesium as a part of the study. So if you remember, the question I asked here was, why do we measure magnesium? So here you have a publication from 2015 looking at prevalence and prognostic importance of dysmagnesiemia in hospitalized patients. And there were quite a few publications in recent years about that. This one summarizes nicely the prevalence number. And conclusion of publications are that around 2% of patients in general population generally will have some form of dysmagnesiemia. But as soon as you move toward the hospital setting, you will see that in hospitalized patients, somewhere up to 20% of the patients in various wards would have altered magnesium homeostasis. And for example, in intensive care patients, up to 50 to 60% can have altered magnesium concentration. And particular patient population like alcoholics, that can go up to 80%. Talking about critical care patients, as I said, that is where researchers look the most effects of magnesium. What are the clinical manifestations of dysmagnesiemia in this patient population? So talking about hypomagnesemia, you can see some of the very serious conditions here, and that's why we are measuring actually magnesium. So list of conditions that can be linked with hypomagnesemia are actually quite long, looking at arrhythmias, hypertension, cardiac insufficiency, coronary vasospasm, heart failure, sudden death, looking at muscle weaknesses, skeletal as well as respiratory muscle weaknesses. And then, as I mentioned earlier, hypokalemia and hypocalcemia. Magnesium is important for maintaining the balance with other cations in the body. Looking at hypomagnesemia again, we can see some adverse effects in this patient population, like hypotension, bradycardia, inhibition of platelet aggregation, respiratory paralysis, heart block, cardiac arrest, and then it can be magnesium supplementation toxicity when you give more magnesium than you should, and that's why it's important to measure it. So hopefully in these first few slides, I managed to explain why do we measure magnesium and what is the importance of measurement of magnesium. In the next few slides, I'll try to explain what do we measure currently in a healthcare setting. So when you send patient blood to the lab, the result you get back is the total magnesium. And that number, that value, fails to distinguish in between three important forms of magnesium in the whole blood and serum. So roughly speaking, around 2/3 of magnesium is ionized, 5 to 15% is complexed with various anions, and 20 to 30% is bound to protein. Protein-bound and ligand-complex magnesium pools are unavailable for biological processes. Ionized magnesium is the physiological active fraction. And if you look here, first, these are reference ranges. So roughly, again, you will see that ionized magnesium is roughly around 2/3 of total magnesium fraction. But if you see equilibrium that exists in the blood, is that magnesium kind of moves in between these different pools, ionized fraction, protein-bound, and bound to various ligands anions. Some of these anions are the anions that exist in the blood anyway, like the phosphate, like bicarbonate, like lactate. And some anions are the anions that we can look as a part of a therapy for patients, especially in the critical care, like citrate, like heparin. And you can imagine that in patients in a critical care setting, especially this part, proteins or anions, various ligands can change. Either we introduce them like citrate or heparin, or protein concentration can be affected. So you can imagine that ionized magnesium fraction can vary a lot, and that's why it's important to measure it. So I've shown you what we measure. We can measure total magnesium, we can measure ionized magnesium, and I mentioned what are the potential dangers if you look in a total magnesium versus ionized magnesium. But I'll try to show you next few slides. Really, does it matter what we measure with examples of some of the published studies in previous years? So here are results of one study done in Australia, published in 2008, where they looked in serum total and ionized magnesium concentration in patients with acute myocardial infarction. So what they've done, they had a group in a control group, around 90 patients, and they had a group with acute myocardial infarction, around 72 patients, and they monitor concentration of total magnesium, ionized magnesium, and creatine kinase MB over a period of, I think, 66 hours in a group with a patient with acute myocardial infarction, and around 40 hours in control group. So they just monitor concentration to see what's happening. In control group, you can see that, as you expect, a stable concentration on both ionized and total magnesium and CKMB. But what happens in acute myocardial infarction group, you can see that basically CKMB goes up, as you would expect in acute myocardial infarction group. Total magnesium concentration is stable, but ionized magnesium concentration drops. With acute condition, you would probably expect that concentration of ionized magnesium will change more rapidly than concentration of total magnesium. So this is one very nice example from a smaller study showing the importance of ionized magnesium versus total magnesium in this clinical setting. So before I go to next few slides where I will present you some other results, I would like just to show you this schematic so you better understand how results are presented in these studies. So here you have a plot where it basically shows total magnesium concentration versus ionized magnesium concentration and what can happen in real life if you would get both results from a lab. So basically, your total magnesium will come, and this is a normal range, whatever low and high values are I showed you before. And this is the plot of ionized magnesium, normal range, low to high. So what can happen? Patient can come, and you can have results that both total and ionized magnesium fits within a normal range, and you would say everything is okay. Or patient can come with a high total and high ionized magnesium, and you wouldn't have any doubts about what the problem is. Or patient can come with low total and low ionized magnesium. So all these cases are sort of, I would put them here in a green, that basically kind of it's a safe zone because both values are showing the same, and you would kind of know where the patient is in regard to its magnesium. But certain percent of patients could show this, actually normal total magnesium values, but actually ionized magnesium is high. And if you have just total magnesium in front of you and not ionized magnesium measurement, you would falsely believe that everything is okay with this patient. In a similar way, you can have low total magnesium and actually normal ionized magnesium fraction. In this patient, in reality, with ionized magnesium being normal, you shouldn't kind of do anything with with magnesium. You shouldn't play with magnesium. But looking at just total, you would say, oh, this patient has a low magnesium. I should load him with some magnesium. And actually, you could push this patient to hypomagnesemia and cause all the problems that come with it, as you remember from the first few slides. In similar way, you can have a normal total but low ionized magnesium. And in this case, you will say, oh, total magnesium is fine, I shouldn't do anything. But actually, that patient is hypomagnesememic, and you should do something about it. So a lot of studies looked in this kind of relationship, and I'll try to present them in the next few slides. So here is the study from 2000, I think published in 2000, looking at magnesium levels in critically ill patients with a subtitle, what should be measured, as we discussed before, total or ionized magnesium. And you will see this curve here, this chart, ionized magnesium versus total magnesium, as I shown before schematically in previous slide. So if I mark the green areas, like the areas where total magnesium and ionized magnesium are aligned concentration in terms of normality, whatever normality is, you will see that there is a certain percentage, around 20% of the patients don't fit this pattern of normal, total, normal ionized magnesium. The biggest disparity here is the number of patients who actually have normal ionized magnesium concentration, but total magnesium concentration is low. And then the next biggest one is the total magnesium is normal, but actually ionized magnesium is hard. And based on this, in around 20% of patients in intensive care unit, you would actually do the wrong therapy on them based on these findings if you would just look in the total magnesium values. So here is another more recent study published in 2017 coming from Massachusetts General Hospital, looking at a similar thing, ionized magnesium versus total magnesium in surgical intensive care unit. And you will again see green represent a line concentration of ionized and total magnesium, but you can see that a significant number of the patients fits in one of the red categories, which is either fast low, fast normal, or fast high. And in these groups, you would prescribe wrong therapy with potential to harm the patient or not help him. And also, this study looked at some laboratory and pharmacy utilization and how much money extra you spend providing wrong therapy and using the lab in the wrong way. And they found some interesting results. It is worthwhile reading this study. So here are results of this study numbers actually showing you, as we discussed, fast normal, fast low, fast high magnesium. Look at the total magnesium, and these numbers are in red, while in black you have kind of aligned values of ionized and total magnesium. So you can see that from around 470 cases they looked, in I think over 140 patients had some of the fast values, either fast low, fast normal, fast high, which comes to roughly around 30% of the patient in intensive surgical care unit had basically misaligned total and ionized magnesium concentration, which means laboratory and pharmacy utilization could have been better in around 30% of the cases. So here is another smaller study coming from Sweden, again looking at the relationship between ionized and total magnesium in serum of patients requiring magnesium status, and they claim there is a weak relationship. And as in previous cases, you can see that alignment of normal total and normal ionized magnesium is not perfect. In the green is again where they're aligned, but again you can see significant proportion of patients, around 20 to 30%, that these values have not been aligned. And this was done in intensive care and primary care, so combined patient population of just 44 consecutive patients admitted to either intensive care unit or primary health centers. Here is another bit older study from 1988, published in 1988, coming from Texas, looking at a similar thing, ionized magnesium versus total magnesium. And this time the difference is that it was done in pediatric intensive care unit. Here is shown again similar chart, but just at this time looking at the normal and low values. Again in green you see where total and ionized magnesium concentration have been aligned. but still significant number of patients show misalignment. So if you were just looking at total magnesium concentration in significant number of patients, you would misjudge their magnesium status. So why we focus on intensive care unit? Simply because of the fact that there can be significant variation in ionized magnesium concentration without corresponding change in total magnesium concentration in these patients, as we have seen in all of these previous studies. And then I explained in this schematic in the beginning how magnesium is split in between ionized fraction and then protein-bound and anion-bound component. In patient critical care and intensive care units, often they have changes in pH, changes in acid-base status, changes in circulating protein concentration, and they will have increased presence of anionic ligands like lactate, citrate, or bicarbonate. So these patients, basically, it's very easy in their situation to switch the balance of magnesium toward one or another, either more bound to protein or less, or bound to ligands or not. So ionized magnesium fraction in this patient is actually the one which is the most relevant. Here we have summarized results from a study from 2011 looking at hypomagnesemia in critical ill patients. So prevalence in various studies in intensive care settings. Mainly parameters they looked were total magnesium, but there was one study you will see from 1996 looking at total and ionized magnesium. So prevalence of hypomagnesemia goes from, let's say, 15-20% coming all the way to 66% if you look in ionized magnesium, or roughly 50% in some of the studies looking at total magnesium. Hypomagnesemia is less prevalent, but still in some of the studies it has been reported with a middle to high single digits or around 12% in one of the studies. So I hope now that the question, why do we measure magnesium and why we want to know ionized and total magnesium concentration difference that can exist there, I think it's much more clearer showing all of these studies previously that have shown the discrepancies there, the prevalence of, for example, hypomagnesemia is quite high in the intensive care unit. And this is just what the fact in real life, but actually what are the outcomes linked with some of these conditions? So talking about outcomes and magnesium, here is the study from 2016 looking at the outcomes of patient intensive care units linked to hypomagnesemia. They summarize the studies that have been done in previous years, and there is obvious link with hypomagnesemia and increased risk of mortality, risk of needing mechanical ventilation, and longer length of stay at ICU units. So all of these were linked with hypomagnesemia. Here are results of, again, looking at the outcomes in intensive care patients, but this time looking at hypermagnesemia, recent cross-sectional study. But again, they showed that hypomagnesemia is a strong independent risk factor for mortality in critical ill patients. So we had the previous study looking at hypomagnesemia, this time hypermagnesemia. So what I didn't tell you for previous two slides, for previous two studies looking at the outcomes and risk linked to hypomagnesemia, that a lot of these studies reported actually don't report the way they measure magnesium, whether it was ionized or total magnesium. But in most of the cases, it was total magnesium because very few technologies exist to measure ionized magnesium. So here is one example study from 2018, looking again at outcomes, hyper and hypomagnesemia in intensive care patients, where they shown actually that hypomagnesemia has increased risk, while hypomagnesemia didn't show any risk, which is in contradiction with the study I've shown you before. But again, if you look carefully here, how do they measure magnesium? They've done it in over 5,000 patients, which is really great retrospective analysis. But looking at the values, they didn't report how they measured, but looking at the values, they obviously measure total magnesium. And knowing what we know, coming back to the beginning of this presentation, how very often values of total and ionized magnesium are misaligned, how we can believe these results. So that's why I'm saying all of these results should be taken with a caution if you are not sure how magnesium concentration is reported, how magnesium was measured, as total or ionized fraction. So last slide to give them more wise, I would ask. We focused on critical ill setting as I try to describe setting where you can easily get the discrepancy between ionized and total magnesium, and in a setting where obviously magnesium is linked to adverse outcomes for the patients. But what's happening in other clinical settings? So here are the few snippets of recent publications looking at ionized magnesium and its value in monitoring patient various conditions outside of a critical ill patients. For example, looking at febrile seizures, looking at asthma, looking at patient hemodialysis, looking at alcohol-dependent patients. More and more in recent years, people are interested really in the role of magnesium in various pathologies. The only thing really I would like you to take away home from this presentation is whenever you are trying to do some research with magnesium linking to any pathology, think about carefully what you are measuring and what you are reporting. So we believe strongly that ionized magnesium is the fraction of magnesium in the blood that you should really look carefully to when you're thinking about outcomes of patients across the clinical care settings. Thank you.